Retina Rounds podcast number 17. We're thrilled to welcome to the Retina Rounds podcast Dr. Firas Rahhal. Dr. Rahhal has been a leader in multiple arenas of ophthalmology. He was a former faculty member and Retina Clinic Director at the Cornell University Department of Ophthalmology. He's a current Adjunct Professor of Ophthalmology at the USC Keck School of Medicine. He's partner of the esteemed Retina-Vitreous Associates Medical Group in Los Angeles, California. And he's the co-founder and general partner of ExSight Ventures, a venture capital firm investing in early-stage companies in ophthalmology and vision sciences. In part one of our interview, Dr. Rahhal talks about the influences of his mentors, the challenges of running a large and busy retina practice, and how he finds time to pursue his passions in medical innovation. Let's check it out.
Delighted to have our giant in retina, Firas Rahhal, with us today, who is a member of a very large and esteemed private practice, academic practice here in the greater Los Angeles area. And Firas, welcome to Retina Rounds.
Thank you, Steve. It's always great fun to do any project with you. We've done many together, and I was looking forward to this just to have a conversation. Thank you for inviting me. It's really kind of you.
Well, it's really a pleasure to have you with me. You know, I think back to the last time I was a guest on your podcast with Jim Mazzo,
Exactly.
and what a treat that was. And I would direct our listeners to find Firas at his work online as well. Firas, our audience is global, and a lot of our listeners are really interested in the journey that brought successful, impactful retinologists and vitreoretinal surgeons to this point in their life. So let's start out by having you tell us a little bit about how you chose medicine and how you ended up in retina.
That's great. Thank you. Choosing medicine is so far back, it becomes a little nebulous, but my parents definitely, we were Syrian immigrants. We'd come from Syria as I was 4 years old, and they always, I think, had the idea that my brother and I would be great professionals, and that's why they emigrated. And the word doctor did come up a lot when I was little. So I think it was, I should probably be on a shrink's couch for this, but I think it was sort of programmed into me to want to do that. And I did end up choosing it and loving it. Retina is, I was more of an adult, so I remember that process really well. And when I got to med school, I had a notion to investigate ophthalmology because of some research I'd done as a college student at Penn under a guy who later became a glaucoma surgeon. He was a fellow at the time. And I liked ophthalmology. I liked the intricacy of the surgery. I liked the fact that the people got better. I found it to be a fairly intellectual exercise to understand eye diseases. And then once I got to residency and had the opportunity we had a great retina department at Cornell. Most people know this from back in those days. I got to scrub with Stanley Chang and Jack Coleman and Harvey Linkoff and Bob Ellsworth and some of the real greats in the posterior segment in those days. And it was a done deal for me. I wanted to be like one of those guys.
And where did you do your fellowship?
I came out west. That was my second foray to the West Coast. I did my fellowship at UC San Diego under the direct tutelage of Bill Freeman, but also Michael Goldbaum. They both were mentors, but I spent more time with Bill. That's the way the fellowship worked. And it was excellent. And I have the greatest respect for Bill. He taught me a ton. No one taught me more in my life about being efficient than Bill Freeman, I think. And he's been a guest on my podcast once, which I really enjoyed.
Well, Bill's a fantastic mentor and a great contributor to our field, and one of the most productive people in our field. And then you went back to the East Coast, as I recall.
I did. It was a surprise and a pleasure. I obviously loved my department. Some people love their residency, others may or may not love the department or whatever. I loved my residency and I loved my department, and Jack Coleman ran it really family style. And I think some programs like that still exist. It was smallish. And when I was looking around for positions in private practice on the West Coast, as I'd promised my wife we would do, because she's from the West Coast, Jack called me, and I thought it was to congratulate me on the birth of our first child in my senior fellowship year, my son Michael. And it turned out he had no knowledge of that. And he was calling me to see if I would be willing to come back to help build up the retina program, because Stanley had exited around the same time I graduated to become the chairman at Columbia, and they were still both great friends, but Jack wanted to repopulate good attendings, and I was super honored to be one of his first calls to do that, and I couldn't pass it up. I talked my wife into moving back to New York with me, and we had a good run there for a while.
Yeah, I would say getting to work with Stanley Chang and Harvey Linkoff and Jack Coleman is quite the coaching tree to come out of. So think back about Jack Coleman and what was your most impactful lesson that you learned from Jack?
Um, I would have to say that leadership is a personal matter. I run a pretty big practice here. I have a lot of employees and fellows who I have to give guidance to. Jack was really one of the greatest leaders I've ever known. His ability to speak publicly and clearly and with direction, both privately and in front of an audience, yet with a degree of warmth and camaraderie was unsurpassed. So from him, I would say I always aspired to learn to be a leader or have leadership skills. I would never compare myself to him. He was such a great leader, but that was his. I think he imparted that on all the residents and young attendings in those days. I really admired that in him.
Now, when I think of Jack Coleman, authenticity, honesty,
Yep.
leadership, incredibly, maybe unparalleled in some ways. The contributions that his department made are legion. But he coupled that with a warmth and kindness, and like you mentioned, family, made everybody, still to this day, makes everybody feel important and heard. Um,
Total
Michael,
gentleman, absolutely a total gentleman, much in the way a Buzz Krieger was here at UCLA. It showed and shows that guys can be in massively profound leadership roles and lead students and other people and still be nice persons with caring and warmth. That still can be done, and these guys did it with great regularity.
yeah, I would actually go one further and say that's why they were so effective, is
Yeah,
because they
yeah,
were real and
yeah.
spectacular, not putting on any airs. Yeah, Jack is one of the greats. And how about your greatest lessons that you learned from Stanley Chang, who's everybody's hero?
Yeah, he he is everybody's hero. He's definitely mine. Every fellow and resident who's ever scrubbed a case with me, dating back 30 years, has heard his name countless times. I learned so much from him clinically. So he's unequivocally the greatest eye surgeon I've ever seen and had the privilege to work with in any subspecialty. I mean, he just had the such a gift for surgery, but also the fact that he was, while being technically gifted, so innovative at the same time. It's hard to be doing both at a high level and operating on VIPs from all over the world and training fellows. And he did it all with this great calm and zen, and he never seemed flustered. I'm sure inside he had moments, but again, um, his decency to people underneath him was so telling. He came and asked me if I wanted a letter of rec when he heard I was going into retina. It was an incredible moment for me because I was sort of terrified to go ask him, not because he was unapproachable, but he was at such a level that I had no idea what my place would be to ask him to waste his time on such a thing. But he knew enough what was going on in the department and cared enough to go see a second year resident in the clinic in the middle of his workday to say, "Hey, I heard you're going into retina. I want to help you." It was amazing. And he did that for everyone.
How about surgically? When you think about the not just the specific tips that he gave you on how to peel a membrane or deal with a certain type of problem, but the synthesized overview surgical philosophies that you took away from working with such a gifted mentor, even though you were just a resident at the time.
Yeah. Um, Patience, his patience surgically is well renowned, as you know, but watching it play out, I didn't realize how challenging it would be to be doing those cases and remain patient. So obviously the technical skill absurd on another level, but his patience and calm through the hardest, most difficult cases, always contemplative, never reactionary, always having a plan that he, I think, brings to the OR in his mind, but when he has to make a change, he executes it with a great deal of calm and a great deal of skill. That's what I remember. And I remember being in awe of it then, but later, as I became a retina surgeon, thinking back on it, was really mesmerized. Like, I can't believe he was doing these things in the manner he was. So I guess the take home message was the maintenance of calm and skill and no change in demeanor or actions despite whatever challenges were being faced. Kind of like they say some of the great athletes, of all time are emotionless. They go to that free throw line and make it no matter what the circumstances are. They look the same. And I felt that way about him.
Yeah, Stanley had an incredible calm, still has an incredible calm about him. And he always had a plan, and he always seemed to be happy. I don't remember ever seeing Stanley anything but he was unflappable. And what a
Yeah,
lot of our younger listeners don't realize is a lot of the greats, in fact, all the greats, had tremendous powers of observation. Their physical exam skills, whether in the intraoperatively or preoperatively, or sometimes other people's postoperatively, were just otherworldly. I Multiple patients I shared with Stanley over the years where I had exhausted my physical exam skills with contact lenses and lots of time spent, and Stanley would write back and say, "I noticed this," and it just completely unraveled the mystery. And
100%.
just
He
so
appropriately gets
generous.
tremendous credit for the surgical innovations, which are all even understated, if anything. But I did work in his clinic. All the senior residents would spend a month with him in his private clinic, which was maybe the best month I had in residency. He does a lot of medical retina, or at least he did in those days. His diagnostic skills are also unsurpassed. He's
Unbelievable.
amazing with a 90 diopter lens and a slit lamp. And I use this as an example all the time. No disrespect meant to my friends in medical retina. They do great work. But I always say to the surgical fellows, there's no reason you can't be just as good at all that stuff. Stanley Chang was just as good at all that stuff while doing 3 hour vitrectomies to midnight, every two nights a week. He still had a terrific bedside manner and a great diagnostic skill set.
Yeah, a lot of people don't realize today that Stanley brought wide angle viewing into the operating room. In those days, we were bouncing everything off a mirror or using a
Yeah,
refractive index and a slant and
yeah,
the old Landers lenses and irrigating contact lenses and so on. And he brought perfluorocarbon liquids, heavy liquids
yeah,
into the OR. And my favorite, personal favorite, because I worked with Stanley so much, was the partnership with Avi Grinblatt and
yeah.
the video editing bays. And so Stanley helped
Love it.
me get the second Avi console outside of the operating room. So at UCLA, we had back in the old room D, the retina room that Buzz Krieger built at Jules Stein, we had what was basically like an NFL level film editing bay right in the OR and a database that categorized our cases in every which way. So one fellow would be assisting the case, the other fellow would be sitting there, and by the time the case was over, we'd have an edited narrative in real time with all the highlights of the case. And that's why when Stanley comes to lecture, even to this day, like when he was your guest at the LAI Society not too long ago, he showed some of the greatest videos you'll ever want to see of, he'll show a cataract complications. He'll show a dropped lens. He'll show a dropped lens, and a dropped IOL. And then he'll show a dropped lens and an IOL where the crystalline lens happens to go under the retina, where the cataract surgeon had tried to do a vitrectomy through the pars plana without really knowing what was going on and created a giant retinal tear. And then he'll even one up that, and both the IOL and the crystalline lens are under the retina. And then he'll even up that one more, and there's a huge myopic staphyloma, and one of the lenses has slipped into this little cave at the back of the eye under the retina. And he's just calmly and happily telling the story, and it's building and building in complexity, and he handles the whole thing. It was
Yeah. And
just
the relationship
remarkable.
with Avi was cool. I was a resident with him in that time that the heavy perfluorocarbon liquid was still referred to then as Stanley's juice in these big vats, and the lenses didn't have a name. And years later, of course, the company got named AVI with an acronym, but really it was, I think, named after Avi, but they made up an acronym to
Of course.
follow along. Avi was
Advanced
in the
Vision
over.
Instruments.
Yeah, exactly. He also, this is lesser known. You'll know about it, but certainly the younger viewers don't. Um, Stanley really brought along what seems so routine now, the use of C3F8 gas in complex PVR as a concept. Really, in the 70s, they barely had use of SF6 for like some very limited usages. And he contemplated actively, we need to use longer acting gas and pursued that. And even complex vitrectomy with gas as a concept, a lot of that came from his early work and his early cases.
Well, it's interesting for the audience members out there who are innovative. What Stanley combined was a great clinician combined with a deep knowledge of engineering and physics. So
Yeah.
he looked, for example, for perfluorocarbons. He looked for immiscibility, that feature where you can tell the difference, the interface with water.
Yep.
He looked for a low vapor pressure so it evaporated quickly. He looked for the ability to treat through it, heavy specific gravity, all of the features that separate that substance into something that makes it so useful as an intraoperative tool. Similarly, as you're telling, with the long-acting inert gases, to find C3F8 was a huge innovation and really changed what we do. And so I encourage our listeners to disrupt and to challenge our conventions as we go forward and try and improve our field and move it forward. The one other aspect of Stanley's work that was so impeccable was his ability to substantiate everything with just flawless evidence. He didn't just put it out there, hey, I've tried three of these, it might work. He was in the lab and demonstrating it, and he was just impeccable. And that's rubbed off on you, Faraz, and that's the way you and your group do their work out here. How about Harvey Linkoff? Did you have much time with Harvey?
A ton. Actually, we spent a second year residence a lot of time with him privately in his clinic, and I'll share some anecdotes there. But then when I went back as an attending after my fellowship, Harvey was still there. And I think when I first got there, definitely he was still operating. He only did buckles, as you probably recall. And I was quite honored that he remembered me for one, and he did. He came down the hall and spoke to me, and he didn't believe he thought vitrectomy was overused, but he thought it had utility for sure. And he used to give them to mostly to Stanley, I think, and Jack. And Jack was the chairman, so he was pretty busy. So he came to me and he said, "Okay, you're going to receive my vitrectomies now," and that kind of terrified me a little because one, he's Harvey Linkoff, and he's one of the world-class geniuses of the history of our specialty. And number two, he'd been used to sending him to a mature Stanley Chang for 20 years, and I was worried about the comparator there. So I took it on, and I really benefited from it because Harvey would actually come up and watch the surgery, or even sometimes give me a buckle as an attending, and then want to scrub with me, probably to see if I knew what I was doing.
Well, he wanted to
He
see if
wouldn't
you
have
were going
said
to
it that.
use he wanted to see if you were going to use the balloon.
Or this, well, I still use sponges. I don't use the balloon, but I have used the balloon. And so back to the residency part, I've done balloons with him. In fact, you may or may not know this. Dave Geyer would know this because he was down the street. Later on, they started dabbling in interferon, as you recall, for AMD. Harvey said, "Well, gee, I mean, you're going to put this toxic stuff in people. Let me put it in my balloon." And we were placing balloons in the orbit retromacular and taping them on the forehead. And we had people from all over the world, including Saudi Arabia, come and stay in New York City for 50 days or up to 2 months. and they would come in every other day, and he would put interferon into the balloon, and the presumption was it would soak into through the posterior sclera, which it did. It turned out not to work very well. But Harvey was incredibly innovative as well, even radically so at times. But I've done the balloon with him, and when I was a second year resident, I spent a couple months on his service, and no one can teach you to draw the retina and find the break better than Harvey Linkoff. It was murderous. It was definitely Socratic teaching, and he would humiliate you.
But you remember.
Everything, and I remember the drawings. Listen, this is how I learned why and how a buckle works, which is, as you know, a lost art. It works because of all of Linkoff's principles. Where's the hole? How do you close the hole, etc. Other people were doing buckles, of course, Charlie Scapins and the group in Boston, but it was just a handful of people in the days that Harvey was younger, before my time, that brought that procedure along from the Custodes procedure, which he quoted all the time. And so learning from him was a treat, because you would definitely hear stuff dating back to legitimately the first retina procedures being done in the world. And that was fun and exciting.
Well, as a tribute to you and knowing full well that you were coming on the podcast, Pradeep Prasad dedicated a couple of issues of Retina Rounds this week to the Linkoff rules, because we
Nice.
knew it was from your coaching tree. And
Yeah.
so that's really, really exciting. So let's shift gears now. You've been on faculty in New York for a while, and you came out to California, and you bumped around a little bit up in Central California, and then you ended up in a very nice spot here in Los Angeles. And together with David Boyer, had the opportunity to learn from and work alongside David and help build Retina-Vitreous Associates into what it is today, which is a quite impressive, high quality academic private practice. Tell us a little bit about your early years in that practice and what it was like.
Yeah, thanks. I, I was dreaming of being able to be in a group like this, honestly. So I did move to California. And actually, I want to thank you. When I first moved to California, to the Central Coast, I was walking away from an academic career, and I knew there would be a big change for me. I had reasons to do it, but I was worried about that aspect of my professional life. And you may recall this. I came to UCLA. You invited me. I gave a talk, and you guys put me on the voluntary, clinical faculty. At the time, Jack had said, "Hey, talk to Bartley, when you get out there, and you should still come down and teach." And I used to religiously drive 2.5 hours every fourth Monday to do the Olive View Clinic. But that was really more for me than for anybody else. And I want to thank you and Buzz. And back in the day, Mark Yoshizumi interviewed me for that. It was more of a formal thing to become a clinical faculty member in those days, I think. Nowadays, I don't know if people go through that, but I really enjoyed it and I appreciated it. I enjoyed coming down for those 3 years to keep my hand in academics.
Well, it's a win for me that you thought it was voluntary because you had no choice. Uh,
Well,
when
Stanley
we
did.
got
I talked to Stanley
when
about.
I got the call from Stanley and from Jack Coleman, it was you have to get this guy on your faculty, and we were prepared to pony up a lot more than we ended up getting out of you, but that was great. And it remains great.
So when I
Actually,
joined,
now it's swung
yeah,
in the other direction now. A lot of the universities have had to trim down their clinical faculty rather dramatically for reasons that have nothing to do with the quality of the volunteer faculty. It just,
yeah, I think it's a loss. I mean, obviously, there's logistics about that are way outside of my purview and understanding. But I remember coming in for those monthly sessions with the OR, and Bob Engstrom used to be there, and then later JP ran it, and Uday was part of that team. And man, the exposure that the residents and fellows would be getting from some of these private guys coming in on a regular basis, not just to teach clinic and surgery, that has great value, but also a lot of them would ask tons of questions about how to start a business, how to review a working contract. And that ended up being a lot of the curbside stuff with the residents. And initially I thought, well, gee, I'm here to operate. And then I learned to appreciate that they saw real value in that and they would ask questions. And I think that part is lost a little now if you lose the voluntary guys who can bring some of that outside experience. But there's a lot of logistics there. And
Well, that's beyond our pay grade. But coming
yeah,
back to
yeah,
you
yeah.
joining that practice that you were so excited to join, what were some of the early lessons for, a lot of our audience or trainees or early in their career? What are some of the takeaways for building a practice that you found to be mistakes, first off, and then to be successes, second off?
Yeah. So what I didn't know this at the beginning, but later on, the biggest observation I made about why and how this practice has been great for a long time and continues to be great is we don't do everything greatly, but we've done really well at selecting new doctors. This is really a thing. It dates back to when David was just him and Gary, and I think they put a lot of effort and energy into being super selective about their new young partners, and that tradition carries on. And actually, a lot of the traditions that David began with Gary back in those days before my time do still carry on. But my earliest observations were really that I'd never seen anyone with the useful clinical memory that David Boyer has. And I mean this as the highest compliment. He can remember almost anything about any patient from 20 years ago. It's phenomenal. And when you consider the volume of clinic time that David has done and for how many years he's done it, and Bob Avery and I talked about this once. It's hard to imagine anyone anywhere that has more clinical direct patient experience in the history of the specialty because he's done it so long. And as you know, he sees so many patients, so many days. And I learned from him that you could do all that and still be really great at other things like building and running clinical trials and partnering with industry and even do some teaching. It wouldn't have occurred to me that you could be doing A+ work in all those different areas until I got here and saw David doing it and Gary to also an equivalent extent at that time. A lot of our listeners don't know I'm referring to Edgar Gary Thomas, who was a legend in the field in his own right and was one of the founding members here with David Boyer. And they both were terrific academicians. They were terrific, super busy clinicians, and they helped design and implement clinical trials. And Gary had interest in engineering, and so he was involved in devices with Alcon. So it was then that I realized I could do some of those things too. It wouldn't have occurred to me that with that kind of volume in the clinic, I would even have the wherewithal to do it. But it turns out you can balance them if you put your mind to it and you're willing to lose a little sleep here and there.
Well, and the other thing I would just emphasize is that you guys take such good care of patients. So let's talk about the lessons. So when you were starting out, and you obviously joined this practice because of its prestige and the possibilities and the opportunity to work with great partners. That's a given, and that's very lucky in and of itself. But let's talk for a minute about, on a personal level, as you were growing your practice, what were the mistakes that you made, if you made any? I mean, it wouldn't surprise me if you didn't make any.
No,
But
I'm
just
sure
for the
I
people
did.
listening to learn what to avoid, it's really a useful question, and our listeners come back to us all the time with this. And I've asked this of many of the greats that have been on our podcast. What were the mistakes that you made or you've seen other people make as they're just starting out?
So I think in private practice, if you're going to do a high volume of retina work out in a small town or a big city like this, it's it's kind of a delicate balance between, everyone talks about the three A's: availability, affability. I forget what they all are, but you get the idea. That's critical. But there's a balance between how much you serve to the referring doctor and how much you serve to the patient. And almost always both are aligned. But there are times that there's a little misalignment between how you might be able to best serve the patient, but may not serve, or the perception of serving the referring doctor isn't quite the same. And that challenged me a little bit in the beginning because there are politics to be had in a referral practice. You have to know how to navigate that. And in the end, when the door closes and you're there with the slit lamp, your first duty, and you're happy to do it, is to make sure you make the best decision for the patient sitting before you. But then a 1B can be to be cognizant of the referral doctors and how they may or may not have managed the patient. And it's a real art form. And David, again, is really one of the great masters at this, is know how to talk to your professional colleagues, know how to interact with them, know how to write a letter to them while maintaining the highest level of vigilance to the care, but not forgetting that your colleagues are also an important part of your practice and business model, your referring colleagues. And to the point you and I've made to each other, your retina colleagues. I've made it, I've seen this in others. This wasn't a mistake that I made, but people sometimes act as though if someone else does what you do in your neck of town, that somehow you can't be friends and partners. And you and I have shown that to be false from 25 years ago. But I also have good friends at USC that we work together, and the other private practitioners in town. But I've seen others come into town that seem to feel differently, that you can't be collegial. It has to be sort of a competition. And that's a big mistake, I think, for everybody.
I agree. I agree. And so balance, it's a really interesting point, the balance between the referring physician and the patient. To me, we feel that balance in academia as well. Everybody feels that balance as a
Yeah.
tertiary care provider. But in the end, it's all about the patient. And in the end, being good to your referring doc is also being good to your patient. Because the
Yeah.
referring doc will have an influence on how that patient turns out. And I think it is a mistake to cut the referring doc out of decision making or any other part of that. It's very important. We're blessed in our town to not only have a great retina community and very collegial for the most part, but also a great ophthalmology and medical community here. But it's not true of everywhere in the world, although I'm happy to say it does seem to be rising, which is fantastic. Is fantastic. So, and what about today for us? So let's talk about the innovations that are not quite so new, but are now in the clinic, right? So we've got a couple of things to talk about that I think our audience would be really curious to hear from you. Just nuts and bolts. When you see a new patient, what imaging studies do you do? Is it diagnostic dependent, or is there a straight set of, do you get a OCT and a wide angle view on every single patient, image on every single patient? What do you do, Dr. Rahhal?
Yeah, I get an OCT basically on every patient, other than maybe an early post-operative patient. And
Hmm.
sometimes they get them too because the staff is so accustomed to doing it. And of course, there's gas in the eye, so it's a worthless test at that juncture. But OCT, I'd say, yeah, standard operating procedure, new and follow-up patients, because the ability to see the macula on the OCT, despite what I probably said 30 years ago or 25 years ago, like, oh, I can see the macula with my 90D lens. It's so exquisite with the OCT
And it's
that
documented.
yeah, and you have to use it for
Right.
everyone.
So you've got an OCT. How about wide angle viewing? Do
The
you
wide
use
angle viewing, I would
wide angle
say more
photography?
selective, more
Right.
selective. If it's anything where autofluorescence can help me, uh, dry AMD/geographic atrophy, Plaquenil screening, all those get fundus photo, but mostly so I can get the autofluorescence part of it. We do those sort of simultaneously in my clinic. And I would say my staff has gotten in the habit of doing Optos wide angle fundus photography for people that have been brought in with any perceived regmatogenous disease, rule out retinal tear, known retinal tear, retinal detachment. So I'd say for peripheral mechanical retinopathies and things, I get a fundus photo on most. And again, for the macula, I like autofluorescence, but not as a routine on everybody, but for those selected 8 or 10 diagnoses where I find it really useful. I don't use fluorescein angiography much, but I do use it if I've examined the patient already. I don't get the FA until I've seen the patient for sure. If they have a new diagnosis of at least, let's say, moderate non-proliferative diabetic retinopathy, I'll generally get at least one wide-angle view to see if I'm wrong and it's proliferative. And I think anyone who thinks they can tell advanced non-proliferative from early proliferative without FA is missing stuff. I think it's nearly impossible because the neovascularization can be so minimal, and then it's up to the clinician what they do with that information. But I want that information. And I would say new AMD cases wet that I'm not sure what's going on. If I'm looking for polypoidal or some other kind of choroidal disease that might not be classic choroidal neovascularization, then an FA on those, but I don't do it routinely on AMD.
How about OCTA angiography?
We've started using it more. I'd say in my group, one of the later adopters, to be fair. I think Dr. Boyer, Dr. Smiley were using it pretty early. They were involved in some of the, I think, early testing of this technology. And so I was a bit of a latecomer to this, but in the last, I'd say 6 months or so, I've started using it a lot more. I find it super useful on vein occlusions and diabetic retinopathy. And one would think, well, that's obvious. These are vascular diseases, but this does obviate the FA in a number of those conditions, even if you were thinking you need an FA. I haven't yet used it consistently because I don't think I'm that skilled at it for AMD interpretation. I find that still for me challenging. Sometimes it looks like a Rorschach test to me, but I'm learning more and more with repeated usage to find details on it that help me with AMD. But that's a learned experience. It was like when we brought ICG along many years ago, a lot of people were ordering it, but in the beginning, we often didn't know what we were really looking for till Larry Yanuzzi and others sort of taught us some of the things to look for. And I think there's still a lot of ground to be made on OCTA, especially with maculopathies that are not classic vascular maculopathies.
Fascinating. And switching gears for the anti-VEGF agents in general, not going to ask you what your favorite is, but I am going to ask you, and I think this is a fair question, and it's a hard question. We all are forced to navigate this landscape of socioeconomics, copays, eligibility, step therapy. Talk to us a little bit about how you approach that, because obviously you put the patient first and their welfare first. And for some cases, there may be a perceived real difference in benefit. And I'm sure in those cases, you're giving whatever you think is best. But for a lot of cases, maybe a generic is where you belong at the beginning, or maybe a dual action antibody is where you belong. And so bispecific is where you belong, or maybe a high dose is where you belong. So what is it, aside from what's best from the patient, that drives you in your practice, and how do you navigate that?
Yeah, this is a great question. It's oft discussed, oft asked, and I appreciate the question. I'm not afraid to get into this with you. Obviously, everybody does it kind of their own way, and there's a little art and there's a little science. Separating, to your point, from what's best for the patient already, we're going to assume that to be point 1A. But then what's best for the patient also then includes what's best financially for the patient too. So for me, the finances of the patient and their coverage are very influential in what I might propose if I think it's a case where there may not be a great deal of difference between which anti-VEGF. Now, this is hunch and anecdote, this part. There are some papers out there. I'll give you an example, not a paper, but my own anecdote. I find that the higher acuity, small kind of classic CNV lesions, when we're talking about wet AMD, do really do better with some name brand drugs over, say, not over, say, let's say bevacizumab, off-label compounded bevacizumab. That's been my personal experience. So I would push hard for that patient to be able to get Eylea or Vabysmo or Eylea HD or one of these. And I see them to do very well very quickly. And I think very quickly is the key part of this, because in those patients in their 2030, if you don't get them extinguished kind of quickly, you lose that visual opportunity. So, but short of that, the majority of people, I think there's a lot of interchangeability. And so I would strictly go based on insurance finance questions. And if the patient's insurance company has a step therapy, which a lot of them do, we'll go through the step therapy process with attention to detail so that if things aren't going well, we know when we're able to switch or petition for a switch. And if the patient asks for a certain drug, and that's uncommon, but in West LA, as you know, some will come in with hey, I'd like to get this drug. I absolutely try to accommodate them and will accommodate them if they assume that any costs that might come out of that, they're willing to accept. I think we're really going to be put to the test now on this, Steve. The question is timely because the Good Days program, which has been in place for a while, very helpful copay assistance for the higher priced name brand drugs, right now is not really effective, if at all. And so a lot of people have drifted back to Avastin who had maybe moved on to name brand. This is by patient's request because they're afraid of the crazy costs that they might face. So to put it in a nutshell, the patient and their insurance company's finance outside of the medical care part really is the other major factor that drives this. And oftentimes that's preeminent if it's a case where I think it won't make a huge difference and it's worthwhile to go through the step process to protect the patient from financial loss. And we use samples a lot in these cases too.
Right. And do you find that the GPOs, for example, Ally or the more traditional GPOs, are able to help you with the coverage? Or do
Yes.
you explain that? Because I think a lot of
Yeah.
our
So
young
I think
domestic providers, also, if you don't mind, explain to our international audience what a GPO is and what
yeah,
we as American providers have to go through to get these drugs, pay for these drugs, how many middlemen there are, and how
it's
they're beneficial to the system and how they're an impediment to the system.
you're so right. This would seem to a Martian to be a completely bizarre system that we have, and you use the word appropriately that this is a series of middlemen. The pharma business, I suspect, in our space for sure, because we're familiar with it, but maybe in all the other spaces, does seem to be an insertion of many middle steps along the way from the manufacturer or the company that makes it down to putting it in the patient's eye. And the GPO step is a group purchasing organization. And these are groups of physicians, presumably working with pharma to improve the cost by a sort of a group buying arrangement. Like you go to Costco and you buy a big 2-pack of Skippy peanut butter. It's a lot cheaper than when you buy the little tiny Skippy peanut butter. And that's kind of the underlying concept is it's creating volume purchasing for across groups of doctors to improve the pricing for the doctors and then thus the patients. And to answer your question, does the GPO help you? They haven't, to my opinion, helped necessarily get the pharma company drug makers to lower their prices, although I think that does happen. They can negotiate price for themselves and then thus pass it on to you. But they've gotten better and better with software in recent years. Ally Retina is particularly good at this. They're brand new, and this is kind of their message, really, is their software systems that they're developing help you to navigate really quickly through the step therapy process for any one payer and any one medical group because there's hundreds of these different payer systems. No one physician could possibly understand them and memorize them all. So software systems are coming about mostly from GPOs and distribution companies, McKesson, Cencora, Ally, these kinds of folks to help streamline this, to also streamline what the expected coverage for that drug would be under that insurance company and that particular drug. What would be the out of pocket for the patient? This is all critical on the fly information. And even now with software, it's still far from great. We're getting better at this. But the
So
patient
explain to
sitting
our
before you, they want
international
to know how much it's going to cost.
explain to our international listeners what step therapy means.
Oh, good. Yeah, sorry, I should have probably done that. Step therapy is simply that the third party payer, what we would usually call an insurance company, sets guidelines, sometimes written, often unwritten, meaning it's communicated in other ways than policy, that you're required to use a certain number of lower cost agents prior to asking for or getting permission and coverage for higher cost agents. And it might look something like for wet AMD, we require, initially 5 monthly injections of compounded off-label Avastin, which is a low-cost product for them, and showing us that it didn't work, that we would then authorize a higher priced brand name ophthalmic drug. And so it's the step part means you're stepping up in cost, and maybe you're also stepping up in clinical efficacy. That's debatable, depends on the patient, but that's the idea. So you're stepping little by little from one drug to the least expensive to the most expensive generally. There are some exceptions to that.
So this is for our listeners. This is why Dr. Rahhal was stating earlier that there are a certain subset of patients with wet AMD where you probably don't want to wait 5 months to determine whether or not a generic is not rapidly effective. And so if you have a high risk, high reward situation, it's better for the patient to use Eylea HD or to use faricimab or to use a non-label product rather than a compounded product that's got perhaps some vagaries to it
Yeah.
versus a situation where it's a smoldering situation. So these payers, in other words, seem to be generalizing all cases within a diagnosis and trying to treat them all the same, thereby taking the decision making for what agent to use out of the physician's hands. And their argument would be that the physician's decision making has been influenced by those that have a
By profit.
financial right by
Yeah.
or by those that have a financial interest in changing our minds or influencing our decision making, i.e., the makers of the product. So that's what step therapy is. You walk up the steps, both in effectiveness, but more importantly, in expense. And so have you found, let's just use Ally as an example. They're a relatively new group purchasing organization that are for and by retina specialists. My understanding, I haven't worked with them before, but they've got a great reputation. And so have you found that this software actually helps your staff understand the step therapy
Yes.
hurdles? And are they
Yes.
able to communicate it to you in real time? And does that affect your decision making?
Yes, I think the software is helping. There's still more work to be done for it to be more comprehensive because we have so many carriers and payers in a place like Los Angeles. But yes, it's helped a lot because I can turn to my tech on a new patient and say, what can we use here? And they'll have a pretty specific answer now. They'll say, if it's a certain HMO, it'll even be up on our EMR, the electronic medical record, when we come into the room. If someone from our billing office has already posted some information based on the working diagnosis of the patient that okay to give blank or need to give this drug initially and then later ask for another drug, that sort of thing. So, yes, it has filtered down to actual day to day clinical operations. But as of yet, I think we need a lot more content. The strategy is good and the software is good, but the content has to grow. And what I mean by that, and again, for the international people or even people in Texas or Indiana, this might seem foreign. It's not even always clear who the payer is. It's not always the insurance company. It's not always the medical group. It could be one or the other, depending on the situation, meaning the local medical group that has some capitation with United Healthcare or Blue Cross, whether the medical group pays or the insurance company pays for the drug changes a lot. And it's hard to sometimes identify all that when you're a new practitioner. It's nearly impossible.
Right, right. And well, that's just fascinating. Let's talk, for example, about the electronic health records. So are most of the electronic health, for example, you're using a brand of electronic health
We're
record?
in we're on the Next Tech program, what is universally called MDI, MD Intellisys,
Uh-huh.
or its original name. It's owned by Next Tech now. We've been on that for a few years.
And does that integrate well with the GPO software?
Yes, and that's a work in progress. But yes, that was one of the things our administrator and CEO Albert Shirakian has done a lot of work with the GPO, Ally in particular, who we're using right now, to help design this software. And one of the missions has been to have it communicate very well and interface with Nextech, and it does. And I'm sure others are doing the same thing. I'm sure, McKesson has a GPO that is also working with the big players in software in, let's say, EHR. And I think Nextech might be in Retina the biggest one. I think it's more than half of Retina practitioners have Nextech/MDI, maybe considerably more than half. So in our space, it wouldn't be that difficult to get pretty good communication across a large swath of retina doctors because of how widespread that particular one is. But if you get to like internal medicine and oncology, there's only 2,000, 2,500 retina practitioners. Who knows how many these other specialists are? It gets more and more difficult as there are so many AHR programs, and that's been a big challenge in private practice to have these interfaces that don't talk to one another. To your
Well,
point,
the other thing that we have that for now at least is there are only, 5 or 10 or 15 agents,
yeah,
depending on where you are and what you're using. But this all can come off as a little bit disheartening for the young retina specialist because this is pretty far afield from the actual practice of medicine and things that people went
yeah,
into the field, the motivators, and so let's just take this hypothetical. If you have a
yeah,
patient who really doesn't want a generic or doesn't want to be in step therapy and they have a coverage, can they go off? Can they go off insurance for that? Or how do you deal with
yeah.
that?
Yeah, it's a tough call. I'm always willing to give the patient what they want, and we will do the work to let them know what their costs would be, and we will help them by utilizing samples when we can and getting discounted prices for them when we can. Obviously, the drug is a mostly a pass-through, so unlike other services that we can provide free and do routinely, OCTs, exams, lasers, the drug has changed things a little because the doctor and the clinic are on the hook for that cost one way or the other. But the companies have been very kind and generous with sampling. Honestly, I got to give a lot of credit here to all the big players, Regeneron, Roche, Amgen now with their product providing lots of samples. We have found that we can, through off-label Avastin and sampling, do a lot of free or very low cost care. And to your point about if somebody wants a higher price branded drug and you can maybe get them started with a few samples, that might be enough for them to accept going to a lower cost one if they want. I mean, the drug companies don't want to hear this, but they may then stabilize enough that they can afford to do something else. That's one strategy. But yes, we always find a way. You know us pretty well. We always find a way to take care of the patient that sits before you and figure out the finances for them if we can help them.
And this whole process of having to be a uh, negotiator around price and decision making, where your decision making, you're in your idealized purified world, you could just choose whichever drug you wanted to use based on only what you thought was best in that particular moment. That's sort of been taken away from you. Does that bruise your ego or get your back up a little bit, or have you just learned to
It
roll with the
doesn't bruise
punches?
my ego or make me upset. I think it's not good. I don't think it's the best case scenario for the nation's healthcare, but I understand the business aspect of it and that the people who are making such decisions aren't doing it with malintent. They're doing it to have some other, let's say, gains or positives in aggregate across a nation, perhaps, or across a large swath of patients, whereas there may be individuals within those groups that are harmed by it. So that's a tough thing for policymakers. But I will say that for most patients still, a lot of our patients with AMD are Medicare aged. That covers, if they have a supplement, pretty much any drug. So probably half the patients, at the very least, do get the doctor and their own choice in which drug to start with.
Which is
And
what's really
probably somewhere
incredible about
around,
Medicare.
yeah, it's Medicare has been pretty cool about these drugs, and that's a debate they're having at the policy side is can we afford to be cool about these things because insurance carriers don't think it's affordable to allow us to pick whatever we want whenever we want. They've put some guardrails on us, and I don't think usually the guardrails are too terrible that you can almost always, if things are not going well, if you're willing to put in the time, and our doctors and staff do, get the medical director on the phone at the medical group and say, look, this guy's not doing well on this drug. I'd really like to switch him. I recognize that we haven't done the 4 steps or whatever. Could you authorize it? And I've rarely been met with no on that, but it does become a then doctor to doctor kind of call or doctor to administrator kind of call.
Right. It's a fascinating trend in our field that the the commoditization of medicine, I call it. We are in some ways the ultimate arbiter of the expertise, and yet we're, as the treating physician, in some ways, the choice is taken away from us. And the patient, of course, has lost a lot of choice. They think they're covered for anything, but really it's proscribed first and second line therapies. And when you understand, and our listeners understand, the difference between real world medicine and clinical trials data, where the inclusion and exclusion criteria are so closely chosen that it doesn't apply to every single patient. So it's a very interesting area. Let me transition to one other area here because your opinion on this is really important to our listeners, and that is, in general, again, how do you treat? Are you a 4 weekly treater? Are you a 2 monthly treater? Are you on-label treater? Are you treat and extend? Are you PRN? And those are even oversimplifications. So instead of pointing to one of those big categories, let's take a couple of scenarios within AMD and a couple of scenarios within, say, DME. That what are the things you're looking for and help you treat? Let's start with age-related macular degeneration, the exudative form, before we get into whether or not you're even in the anti-complement world for the dry patients.
Yeah, there are some clinical features, but on the whole, before I get into that, I've kind of come to, and this is having dabbled in all of the different strategies at different times. We've doing this a long time now, almost 20 years. Um, I generally have come to, certainly in wet AMD, and I think also for DME, that I tell the patient the first 3 or 4 months, I'm going to give them a monthly injection. That is basically on label for most of the drugs. I don't know but I don't do it because it's on label. I do think it's a good strategy, sort of a loading dose idea. I do believe there's some merit to that. And I'm particularly aggressive about monthly if there's a good deal of hemorrhage in a macular degeneration patient, a wet AMD.
So there's a
But
clinical feature.
yeah, that's a clinical feature. So if somebody comes in, they got anything more than a dot hemorrhage, I'm going to do monthly for at least 3 to 4 months for sure before I even consider treat and extend. And then I'll consider treat and extend when the OCT is normalized and the hemorrhage is gone. And that's usually relatively fast unless it's a huge hemorrhage, different story. For somebody that doesn't have that much hemorrhage, maybe a dot and a fluid, I'll still more often than not, much more often than not, do the 3 months, and then I'll kind of quickly move to a treat and extend, typically if the OCT has become dry. And I'm fairly at that point less aggressive than a lot of people. I'll extend pretty quickly, and I'm a little bit fluid tolerant more than some others, depending on where it is and what the vision is. If it's a little subretinal fluid, uh, I won't, and no intraretinal fluid and no hemorrhage and no vision loss, I won't rebump them back to monthly or shorten the duration. I'll keep staying at that extension, 6 or 8 weeks or 10 weeks or whatever I've reached. I'll start decreasing that if things like hemorrhage start occurring or vision loss or intraretinal edema. So those are some of the clinical features I look for.
Thank you, Dr. Rahhal, for joining us for an interesting conversation about the nuanced insights into retinal care here in Los Angeles and how you manage and deal with different aspects of patient care and the politics of private practice. And really, thank you for sharing your journey. For the audience, we're going to have Dr. Rahhal back later this summer for an hour on retinal innovation, what makes a good venture startup, and how to get a company funded. Thanks very much.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.